is Dr. Centeno, and thanks for joining me to just talk about anything regenerative medicine related, craniocervical instability related, PICL, posterior, etc. So this could be my last Facebook Live before I head out on sabbatical. Probably going to try to do one more the middle of next week. So we'll see how that goes. But just wanted to make myself available to answer questions. And as usual, we'll start talking about a little bit of something until we get a bunch of people on. So this is the CCI image analysis tool. I posted it on Reddit. And I created this to primarily be able to index all of the measurements that can delineate CCI that we can find on movement-based imaging. So you can get the link for this. I'll put it in the show description. But basically, the CCI image analysis tool allows you or your doctor to figure out if you've got CCI. So press that button. Here are all the different references that go with what we're talking about. And let's go back that way. There we go. But let's say you wanted to say that you had 6 millimeters of overhang here on the right and 2 on the left. And let's say you have 3 millimeters of ADI there, and you're 50 years old. You go down to the bottom and analyze parameters, and here it tells you that you've got type 2B CCI and type 2A CCI. Good morning, Mark. Good to see you. Again, if you want to ask questions, just put those in the comment section, and I'll be happy to start to answer those questions. So as you can see here, it also gives you a little chance to watch a video on each CCI type. And you can, put in lots of different measurements here. Let's say if we put in the BDI, let's say we had 6 millimeters in flexion and 10 millimeters in neutral and 12 millimeters in extension. And then if we go down here and analyze parameters, it will have added type 1C CCI here, telling me why that's a 1C CCI. So lots of different things here that you can take a look at, but created this just so that everyone has a chance to be able to figure out what type of CCI they have. You can also send it to your doctor, who can also go ahead and use this tool as well. So let's see here. Mark has a question. Is MRI DTI helpful? Mark, when it comes to MRI, the type of MRI that we really need to see is a flexion extension MRI, so an upright flexion extension MRI. And that means that you are seated in the MRI machine and you look down all the way and you look back up all the way. That will allow us to tell if you have certain types of craniocervical instability. Now, it's not perfect. There may be other types that misses, but that's the kind of MRI we need. But a routine MRI would be much less likely to show craniocervical instability. And then you've asked a question about DTI, or diffusion tensor imaging. Diffusion tensor imaging is where we look to see if there's been any damage to the brain or the brain stem, and even the spinal cord. And yeah, that could be helpful if we were concerned about damage there. So we'd be looking for something called fractional anisotropy, or FA there, or FA values, to try to see if there's good flow through the neurons or the neural pathways in that area. So that's what a DTI MRI allows us to figure out. Michael, hey, thanks for doing this. If you need MEI imaging for live teaching, I can try to send mine over. I think we're good. There's so many different issues involved there with regard to HIPAA. Probably not a great idea for me to do online like this. Mercia, good morning, doctor. Are EPICL latest techniques equally practiced by CSC practitioners as of now? Yeah, so Mercia, what Mercia is talking about is that we upgraded from the PICL to the EPICL procedure. And in the EPICL procedure, that took a while to get everyone educated, but at this point, everyone's educated on the EPICL upgrade. So everyone's going to be doing that the same throughout the clinic. So it doesn't matter if you see myself, Dr. Schultz, or Dr. Pitts, everyone will be able to do that EPICL procedure. And that's really a big difference maker from what we're seeing, meaning it's a much more advanced technique than the old PICL. It allows us to get certain ligaments with far greater accuracy. So, but yes, everyone throughout the clinic knows how to do that. Thanks, Mark. Do you have any questions? If anyone's got any questions, just post those and I'm happy to answer them. And so I was going over while we're waiting for people to post some questions. If you want to post a question, just go ahead and write that question in the comments, whether on YouTube or on Facebook. It'll appear for me to take a look at. So this is that CCI image analysis app I created. Again, you can input your values right here. And then once you go ahead and push analyze here at the bottom, it'll tell you what types of CCI you have, why you have that type of CCI, allow you to watch a video on that type of CCI, etc. So pretty cool little app here. And we'll go ahead and we'll put the link to that in the description so that afterwards you can hit that and send it to your doctors, etc. Okay, bunch of questions coming in now. Submit advanced by Sherry Scott. Can we request you to do the EPICL procedure? I assume the waiting list would be longer. Not sure what you mean by that. Sherry, all we really do is the EPICL procedure these days. We don't do the routine old PICL anymore. So anyone that gets a PICL procedure these days is going to get that EPICL upgrade. Amanda, can you have neck crepitus without instability? Can this have any relationship to facet hypertrophy in the upper neck? I'm going to switch this out here. So we'll go into the more routine mode here. So can you have neck crepitus without instability? Yes. In the same way, Amanda, that you can have crepitus. So crepitus, just so everyone understands what that means. Crepitus means crunching in a joint. And an example of a kind of crepitus is when you crack your knuckles. So you can have crepitus or joint cracking or noises without instability because the joints are arthritic. Now, with instability, you're going to experience crepitus as well. So both kinds of joint states, either arthritis and or instability, would cause crepitus. At Dr. Centeno, I'm trying to differentiate whether my symptoms are from CCI or elongated styloids. Less than 50% IJV compression and neutral, dynamic imaging and CTA with contrast show evidence of both. I'd like your thoughts on the best treatment approach. Current symptoms, left-sided pinpoint neck ache, posterior SCM, sometimes into upper trap, left tonsil pain, intermittent ear pain, and sensation of something in my throat when swallowing, and fullness in the left SCM, pain and pulling, and then it kind of... Karen, I really can't give an online diagnosis. What I can say for sure is that lots of people have IJV stenosis on imaging who have no symptoms at all. So the fact that you have IJV stenosis on imaging doesn't mean much because we can find people walking around the street right now who have no symptoms who will have a similar looking image. At the end of the day, when you're talking about craniocervical instability is something that involves a neck injury and neck pain. It tends to have headaches, dizziness, imbalance, and other things. Those other things can include throat issues, etc. Having said that, when it comes to just a pure Eagle syndrome without craniocervical instability will be mostly just the other symptoms, right? There's nothing about this that generally causes a lot of neck pain. It just would be things like symptoms related to IJV compression, for example. If that's severe, you might get tinnitus, or you might get cranial nerve 9 symptoms at the back of the throat without the neck component. So in general, if there's a big neck component, it's probably not Eagle, or if it is Eagle, it's Eagle due to the neck issue, and the focus is the neck. If it's more just the back of the throat issues and or things like tinnitus, which can be related to compression of the IJV, then you might think Eagle. Christine, what would be the timing for the stem cell support you have before, after, for how long? I think, Christine, you're talking about the stem cell support formula. So the timing for the stem cell support formula would generally be for about 6 weeks before and about 6 weeks after. Now, a lot of people get quite a bit of an anti-inflammatory effect from that stem cell support formula. So from that standpoint, they kind of just stay on it because they like it. But those are sort of the minimums for that stem cell support formula. Crane, hi, Dr. Centeno. I quickly wanted to ask you if you have studied or know of any relationship between oral posture, tongue posture, and CCI, and whether or not a frenectomy is worth considering before EPICL. Yeah, so the answer is no. I mean, I don't think there's a relationship between a tight frenulum or being tongue-tied and craniocervical instability. And in fact, the frenulum, just like the stihyoid ligament we were just talking about in Eagle syndrome, are both related to secondary neck instability. So if you cut the frenulum, you're going to get more neck instability. Same thing if you cut the stihyoid ligament for Eagle syndrome, you're going to get more neck instability. So if you've got craniocervical instability, then I'd recommend first that you go ahead and get that taken care of, because cutting the frenulum, I don't think is going to help a CCI patient. And I've seen lots of CCI patients where that's been done and it didn't do anything positive. Randy, can PRP stem cells help with occipital neuralgia? Yes, I think the first question, Randy, is what's causing the occipital neuralgia. So, we have to be careful there, right? Occipital neuralgia just doesn't happen for no reason. There's a cause. And so what is that cause? Is that cause bad posture, in which case you've got to treat it and fix the posture? Is that cause craniocervical instability, in which case you've got to treat the craniocervical instability and the occipital neuralgia? Or is the cause something else entirely that has yet to be diagnosed? So occipital neuralgia just doesn't happen. It happens for a reason. And yes, it can be easily treated with platelet lysate, PRP, etc. Ultrasound guided hydrodissection of those occipital nerves. But you also got to figure out the cause. It just doesn't happen for no reason. Edgar, are EPICLs contrast confirmed for alar and transverse other ligaments? Yes, always, Edgar. We don't do anything in that space without contrast confirmation. So what that means is it's the procedure we're talking about here, the EPICL procedure, is a dual axis X-ray. So that means it's really 3D stereotactic. So that means it's an AP X-ray beam going this way and a lateral X-ray beam going that way at the same time. And then we also use a specialized 5th generation 3D printed mouthpiece to keep the tongue down out of the way. We use an endoscope to visualize the back of the throat. Patients fully asleep for this. And then once we access those ligament areas, we inject contrast to make sure that we're in the right place and the right ligament. If not, we adjust. And then once we confirm that we're in the right ligament, we then go ahead and inject the bone marrow concentrate. Marcia, thanks, doctor. Would you say CCI instability is brainstem compression focused research is picking up nowadays, or is it still lacking in mainstream medicine? Still pretty slow. We're performing research in this space. I know Henderson is performing research in this space. A little bit of research out of Klinge et al., but that's about it right now as far as people who are researching this with regard to treatment. Every once in a while, you'll see a paper come out regarding anatomy, but not a lot's being done. No, I would say that if anything, it's super slow. Nino, can you do my analysis live if I post the numbers? Sure, Nino. Just realize you're sort of giving up your rights under HIPAA then. The U.S. has HIPAA laws. So not quite sure how that works. But if you post the numbers, I can certainly put them into the app that I was just showing you for sure. Carol, submit advance by Harry Winston. What would you need to do in advance to arrange for nursing help? Post-PICL, I usually have difficulty recovering from any type of procedure. Yeah, that's a great question. So we do have nursing support. We have usually a single nurse that we contract with that knows our patient population, knows our protocols. And that nurse can go with you the first night, especially to your hotel room, can stay in your hotel room. And the goal there is to have somebody for support, right? Is to, if you're not traveling with somebody, is to have someone who knows when the doctor needs to be called, or if the doctor needs to be called, who knows what's pretty routine, who can get you things, help you, that kind of stuff. So yeah, that's a good idea, especially if you're traveling alone. Lisa, I understand that vision problems are coming from my neck. However, I did have 10 plus years of Botox around my eyes, probably twice per year. I'm concerned that may have caused further damage. You know, Lisa, that's generally not going to cause damage to your eyes in general. I think instead, more commonly, if you've got upper cervical issues and craniocervical instability, it's certainly possible that you're getting bad proprioceptive input, which is messing up your eye movements, and that's then leading to visual problems. You can also get abnormal sympathetic nerve input, which can also cause problems with the pupils. Both can mess up eyesight and vision. So wouldn't be too concerned about the Botox around the eyes. Existential epidemiologist, can thoracic PRP injections be done without ultrasound guidance? Can you inject thoracic spine the same as PICL? Yeah, so thoracic injections in particular would be pretty dangerous without imaging guidance, right? The biggest problem there is going to be that if you're going to inject any deep structure in the thoracic spine, if you were to veer off course, you can get into the lung field and puncture a lung. So that's one of the reasons why we would use ultrasound guidance if we're doing anything in the thoracic spine there. Now, if you've got a thin patient and they can, you can easily palpate the ribs, sometimes that's fine. You can sort of pursue a safe technique and get the rib between your fingers as the doctor, and then pepper the rib itself or the rib fascia. But as far as a thoracic spine injection into the thoracic spine, facets, epidural, etc., that's going to be imaging guidance. That's going to be fluoroscopy with contrast confirmation and or ultrasound, depending what it is you're trying to do. And then, sorry, going back to existential here, yes, we can do all of that during a PICL. So I get that question as well. Submitted advance by Sherry Scott. To set up an appointment with Dr. Bluestein pre-post procedure, would that be done through her office or through her directly? No, that would definitely be done through her directly. Dr. Bluestein is an expert on hypermobile EDS, and we share a lot of patients, but it would definitely have to be done through her office directly. Nino, found May-Thurner syndrome, vascular eagle syndrome, and CCI along with other things. But those three, which fire should I put out first? 4 points of compressed arteries in the neck, then MTS. Nino, I'd need to know a lot more than you're posting, so it's hard for me to answer that question. Yeah, I'd need to know a lot more, which four veins, arteries, what kind of imaging we're talking about. Have to be careful when we're looking at vascular imaging in the neck. I think I was already mentioning that IJV compression in normal individuals is common. So if we do a CT venogram or an MRA or an ultrasound and we happen to see IJV compression, it's one of those things where you're like, you don't know what to make of it, because there's a lot of people walking around the street with IJV compression who have no symptoms. Christian, have you seen cases of TMJ degeneration after getting CCI? TMJ sand sounds, pressure, sensation, pulling the TMJ apart. Yeah, Christian, I think I've said this many times here, and that is that craniocervical instability and the TMJ are very linked. And that's because you can use the muscles of mastication and the strap muscles in the anterior neck as a way to stabilize the head on the neck. So because of that, when these deep upper cervical muscles go offline and start to atrophy, you start to overload the TMJ, or many patients do, and then you start to get separate TMJ problems. And so we're often treating the TMJ at the same time as we are treating someone's neck. So PICL procedure plus TMJ is very, very common for us. May just add that. Dr. Centeno, I'm in extreme dysautonomia. My blood pressure is low. I suspect I have CCI. If it's safe for me to get treated in your clinic. Well, the first thing is we need a diagnosis, right? So let's go through that. How to get a diagnosis for craniocervical instability, to rule that in or rule that out. The first thing that you would need is obviously to see a doctor that understands CCI. You would need to get movement-based imaging. That might be a DMX, upright flexion extension, MRI, etc. And then if you've got CCI, that CCI would be typed 1A, 1C, 2A, 2B, 3A, 3B, whatever that is. And that then tells us which ligaments are involved and whether or not you'd be a candidate for an injection-based treatment, whether that's going to be PICL or posterior, or even a surgical candidate. And then from there, we can certainly evaluate the dysautonomia and see if that seems to be related to the CCI and how best to treat that. So that might be something like hydrodissection of the vagus nerve and injecting platelet growth factors around that at the same time that we're treating the patient with a PICL procedure. Some ask, how common is scoliosis at C2-3? How is it treated usually if you are familiar? Scoliosis at C2-3, I think what you would be saying there is maybe that scoliosis has its apex at C2-3. So that's certainly possible. We see that, meaning scoliosis means a curve. So that curve would occur across multiple vertebrae, not just at a single vertebra. So at the end of the day, yes, it's possible to have C2-3 be the apex of that curve or scoliosis. And that can certainly impact, for example, the upper cervical spine. C1-2, C0, C1 is going to cause rotation there by default. So that rotation there can cause all sorts of problems. So scoliosis is something that may need to be treated at the same time as the CCI. May I just add that? Do you have clients with dysautonomia get better after getting treated by a PICL procedure? Yes, I would say right now, these days, about 1 in 3 of our CCI patients have dysautonomia, and most of those patients are getting better from that dysautonomia. Usually we're treating both the craniocervical instability and the other causes of the dysautonomia, just like the vagus nerve hydrodissection that I discussed. Crane, with regards to frenectomy, and it is not positively affecting CCI symptoms, if it's being recommended by a dentist, wouldn't the increased tongue support along with your palate help stabilize the spine? Not really. Crane, I just don't buy this whole dentist thing of cutting the frenulum. And I haven't seen it produce good things in the CCI patients that have tried it. So at the end of the day, I wouldn't recommend it for a CCI patient at all. Now, again, like everything I've said on here, you've got to first get diagnosis with, or you have to first get a CCI diagnosis. And then from there, you can certainly determine, do you want to treat the CCI first? Do you want to get the frenectomy first? If you have CCI of certain types, I certainly wouldn't recommend getting the frenectomy first, based on my clinical experience and lots of patients who have had CCI who have had their frenulum cut. Greg, just FYI, you have another live open. A few of us were waiting on. Another live open, a few of you are waiting on. Let's see, right now I am on 2 Facebook channels and a YouTube. Hopefully this is streaming to all 3. Greg, does DMX allow measurement of CXA? Have one scheduled before I meet up with you. Had up MRI tech, didn't rally, no placements. No readings, had to ask, said CXA 125, could be read or done incorrectly. DMX doesn't really allow for measurement of CXA with any accuracy, nor do flexion extension x-rays. The reason is it's very hard to see the basion. Now, some flexion extension x-rays or some DMXs may be easier to read a CXA on. But in general, the most accurate way to get a CXA would be something like a CT scan, preferably with flexion extension. Usually that's a flexion extension CBCT, or an upright MRI with flexion extension. That can get an accurate CXA. As far as MRI techs and radiologists, in my experience, if they're not measuring these things all day long every day, they're not all that accurate. I've seen a lot of radiologists get this wrong. There's some guidelines for how to measure CXA, for example, in the Nicholson et al. Paper that was just published 3 or 4 years ago. So probably would get that reread. Eric, I got my first ocular kaleidoscope looking something line in my left eye in my life this morning. I walked around the block last night and walking irritated something, and it's really deep within tense muscles feeling. Took 37 minutes to go away. Went to stand up dynamic MRI North South Carolina VA. Gotcha, Eric. Kaleidoscope type sensations don't tend to be common in CCI patients. That's one I haven't heard a lot of in my CCI population. Christian, does it make sense to align rotated C1, C2 that's got recently unstable, but has been rotated for many years with NUCA or AO? Yeah, Christian, I think it's always a good idea to try low force upper cervical chiropractic. That could be NUCA, AO, Blair, orthospinology, etc. To try to get that back into alignment. Even if it doesn't stay there, then at least you have that data point that someone was treating your upper cervical spine, trying to get alignment, and it helped or didn't help. And that's helpful for guys like me to have another data point that we're either treating the right thing by treating your CCI or not, because we want as many data points as possible that we're heading in the right direction with that patient. So I'm curious how PRP is used post-fusion patients. Yeah, the biggest problem post-fusion is adjacent segment disease. So adjacent segment disease, or ASD, means that once you fuse something, the levels above and below the fusion move around too much. And by moving around too much, they can get arthritic over time and become symptomatic. So usually in fusion patients, we're treating that ASD, which is commonly above and below the fusion. Lisa, my question is, do you think my Botox use further may have worsened my CCI? If it's around the eyes, I don't think it probably worsened that. No, that would be cosmetic in the face. Botox use would be the least likely to cause any problems or issues with CCI. So I think it's unlikely that there's any overlap there. Nathan, do you have DMX machine at your clinic? If not, are there any recommended locations nationwide? I'm having trouble finding less than a 5-hour drive, so I'll probably fly somewhere. Yeah, Nathan, right now we use Dr. Katz's office, who's close to our office, maybe 10, 12 miles away. We will be getting our own DMX machine, and it should be online by first of the year, December, something like that. So when it comes to getting it done, if you're going to be coming in that time frame, you'll probably just get it done at our office. Now, you can obviously always try to find one and fly to one as well. That's another option. But let's say come December, January, we should have a DMX machine in the office. Cynthia, the new CCI analysis will allow doctors to use quantifiable numbers to give a possible CCI diagnosis. But are there patients who just don't have the numbers that can be measured in the imaging due to muscle guarding? Yeah, so I think, Cynthia, you bring up an important point, and that is that in movement-based imaging, it's really critical to get a complete movement, right? So if you're doing flexion extension, for example, you got to really crank it into flexion. You've got to really crank it into extension to show that. And then sometimes muscle spasms and guarding will make it look like the person doesn't have any abnormal motion. Or if you're doing a DMX open mouth, you've got to really crank it in that lateral bending maneuver. Now, if you think that could be a possibility, the doctor can give you things like Valium, for example, or muscle relaxers to take before the imaging so you can max out the range of motion. But maxing out the range of motion is really required for reducing that false negative rate, meaning, we read out an image as normal, but there was instability there because, the muscle spasm, as you bring up, obscured it. Vivek, you're awesome, Dr. C. Thanks for your time and passion helping us. How many weeks post-PICL should we start laser exercises? I know thread the needle, so I guess start level 0 this week, mark 7. Yeah, so Vivek, I think if you're feeling good, that would be fine to start now with your laser exercises. And there, the thing is, progress slowly. If you come up against resistance, and what I mean by resistance is it's really causing a flare-up in symptoms, then back off and wait some more time, and then try to progress and get a little further, and then you might push it too far and back off. Again, thread that needle. But yes, this is about a good time to start those laser exercises for most patients. Brittany, I am new to all of this. I do have a DMX X-ray and it showed issues. I'm working on getting all of my info to you. I've also had mildly low lying tonsils on my MRIs and all been supine. I had a normal cine MRI, also supine. I developed POTS last year and met the Brighton score for HEDS. Long story short is I've had an immense amount of stress on my body and have been flight or fight mode for a very long time. So Brittany, if you've got a DMX that showed issues, the next step is to get a CCI type and then obviously a telemedicine to look at all of that in context and see what your options would be. Greg, any other imaging other than DMX or other outside recommendations you would need before a late October visit with you? Yeah, Greg, really our goal with a telemedicine is to get to the point of whether or not someone has craniocervical instability. If you've already jumped through that hoop, then getting a DMX if you don't have one is helpful, because then we can use it for tracking purposes. So nothing really outside of that if you've already been qualified as having craniocervical instability. It's all right. I'm not worried about my PPI. Here's where the radiologist found issue, Bayesian axis in the middle. Yeah, so, well, we can certainly put that in our little handy dandy thing here. Let's see if I can get back to that. I think I've got to switch the share here, guys. Hold on a second. Okay, here we go. Okay, so you had a, I could do that in my head, but let's use this thing here. Maybe we'll refresh it to clear it. Okay, so we'll just go down to BAI. So this is, for those of you who didn't see this, this is a little app I created, and the purpose of this app is you can just input your numbers into it to see if you meet the criteria based on the peer-reviewed literature for CCI. So BAI in flexion is 8.2. So let's put that in here. And your BAI in neutral is 4.6. And your BAI in extension is 3.9. Now I know the answer to that, but let's do it anyway. So we can analyze parameters here. So yeah, so that does meet the translational BAI requirement for a type 1C CCI. You can then watch the video here about what a 1C CCI or a type 1C CCI looks like and what that is. It also goes here, tells you about that you're more likely going to need an EPICL procedure, and then you can learn about the procedure. So that's how that works. So Nito, that would be a type 1C based on those numbers. So let's get rid of that and go back to this. Okay. Latifa, can I threat neck instability natural, or can I treat neck instability natural ways? Yes, you always should try to treat any type of neck instability, including craniocervical instability or instability at the very top of the neck, through physical therapy, upper cervical chiropractic, and just a test of time and trying to improve your activity. Now, if you get into the 3-4 month range and none of that is helping, then that's when you start to look at whether or not you might need assistance from injection-based therapies. But the default is always try to treat it conservatively. Christian, have you seen facet arthrosis and sounds getting better after facet PRP injections? So have we seen arthritis in the facet joints that produces sounds get better after a PRP injection? We have, but realize that most patients really aren't too concerned about the sounds. They're coming to us because usually that facet joint is causing pain, whether that's headache pain, neck pain, upper back pain, etc. John, do you guys have a DMX at the clinic? Right now, we're using Dr. Katz in Boulder, about 12 miles away. We do have a DMX on order for our clinic. It should be there, I'm hoping November, but you never know. Let's add a month to that just for wiggle room. So hoping that we'll have it by December and it'll be in full use come January. Submitted advance by Harry Winston. What amount of time would we need in Colorado post-PICL before flying back to London, for example? Yeah, so that's a good question. Most international patients for a PICL generally stay the week. So I'll give you an example. Someone gets a PICL on a Monday, and then they stay in Colorado, usually till Friday or so, and then they'll head back. Now, for domestic PICL patients, if they're coming from another state, in the US, it's usually much shorter than that. If they're a sensitive patient, they might give themselves a couple days. If they're a more robust patient who's doing more, they might give themselves, 1 day afterwards and leave the next day. Existential epidemiologist. When is Invisalign generally okay to try in a patient with CCI? I've just had PICL number 1. I know it can cause issues for some with CCI, but having jaw issues from dental crowding also. We don't have a ton of CCI patients who are actively getting Invisalign done. So my sense is it's probably not going to be an issue. But again, don't have a large patient subset who have gotten Invisalign done for me to say most of them have problems with it post PICL or don't. But my sense would be it's probably not going to be an issue. Snowmass, skull tightness eases with pressure points at the suboccipital area. Would this be from CCI or other? Well, that's a pretty common pressure point, snowmass, for the occipital nerve, right? So the greater occipital nerve comes out here, the lesser occipital nerve comes out here, the third occipital nerve comes out more towards the middle. So if you've got headaches due to the occipital nerves and you put pressure over one of those nerves, in some cases, it's going to block the nerve and make your headache pain feel better. So that at least tells you that you probably have some sort of low-level occipital neuralgia. If it's high level, the pressure generally goes the other way. The pressure generally pisses it off. Now, again, same question as before. What's causing the occipital neuralgia here is key. So you really need to figure that part out. Is it craniocervical instability? Is it postural? Again, occipital neuralgia just doesn't happen. It happens for a reason. And unless you figure out the reason, you're never going to get rid of it, even if you treat it directly. Brittany, what out-of-the-box symptoms do you see people have with CCI? Well, Brittany, there's lots of different types of symptoms out there for patients with CCI. They cluster around headaches, upper neck pain, dizziness, and balance. But then there's a whole host of other less common symptoms that many CCI patients have: tachycardia, POTS-like symptoms, gastroparesis, GI-like symptoms, sort of a whole host of other autonomic issues that can come through things like vagus nerve irritation, or visual symptoms that come from bad proprioception or sympathetic irritation. So again, lots of different symptoms. And that's one of the hard parts about this problem, is that there are some core symptoms, but there's a long tail of symptoms that you can get outside the core symptoms. And that generally confuses the medical care system, because then patients get the $1 million workup and nothing's found. Zigzag, does your clinic do hydrodissection of the superior cervical sympathetic ganglion? Possibly good for those with visual symptoms. We can do that if we think that's something that needs to be done, yes. Just realize that everything in medicine is risk-benefit. So we're constantly asking ourselves, what's the risk of doing this? What's the possible benefit of doing this? Great, Crane. Happy to help. Jesse, do you have any tips for relief for the people who have had CCI but can't afford the treatments or surgeries? Yeah. So again, Jesse, we have the PICL pro bono program, which is getting off the ground now. Regrettably, my office isn't doing a great job of processing all of that. So we're going to get on them this next week to figure it out. But it's supposed to be 15 slots per year for the most needy patients that can't afford this kind of treatment. Now, it's going to be focused on the PICL procedure, so that person has to be a really good PICL candidate. That person has to be lower in income than the US poverty rate. That person can't have had any prior PICLs. And in general, then you can compete for a slot. Now, compete is just going to be random voting if there's more than one person for that slot. But the goal is to get that out to at least 15 people a year who can't afford this type of stuff. In addition, through the Regenix program, if you're a US citizen, we have 4,200 companies that cover this. So if you work for one of those companies, and there are ways to check to see if your company covers this, then you can also get it paid for through your company's insurance benefits. Andrea, I just had my first PICL a week and a half ago by Dr. Schultz. I had relief of my neurosymptoms in the first 3 days. Assuming from the swelling and fresh bone marrow in the area, I'm back to having all the neurosymptoms now and worse, which I know is a good sign. What week do patients start to see neurosymptoms? Yeah, so Andrew, I think what you're describing is what we call the donut hole, right? When we inject those ligaments initially, they tend to be tender, but they're swollen and tight. And because they're swollen and tight, they're providing stability. And then a lot of the symptoms go down because the person's stable. Now, eventually that acute inflammation and swelling goes away. That's the donut hole. And then all the instability comes back. And then all the symptoms come back. Then, as things remodel and restructure, usually at around the 2-3 month time frame, then the person gets more stable and the symptoms start abating again. So that's usually what happens. Snow asks, if room spinning dizziness can be induced from pressing down on one side of head on the pillow, is it the C2 nerve or vascular cause? I think what you're describing sounds a lot like someone who might have C1, C2 instability, because we'll frequently hear that they feel like things shift when they're lying on the side with the pillow here. And that makes sense because C1 and C2 are literally laterally shifting. Now, could be other things as well, but that's something that sounds like it fits. So that could be a type 2B instability. May I just add that? We're in California, LA area. Can I get a DMX imaging? Do I need a script to do it? Do you provide it? Yeah, so you generally don't need a script for it. And we've got a list. So if you contact my office, they can give you a list of places, but a lot of times it's easy just to Google it. If you Google DMX cervical, don't just Google DMX because there's apparently a rapper named DMX. I didn't know that until I started searching it. But you have to Google DMX cervical California, DMX cervical LA, whatever it is, to try to find one more locally there. And that's probably just as good. Or even use ChatGPT, right? ChatGPT can do an advanced search where you can say, I'm looking for a digital motion X-ray in the state of California. Can you please list all of the websites that talk about that and locations and phone numbers, and it'll give you that information. Cassian, if a state doesn't have a DMX, what conditions does a flexion extension MRI assess that a flexion extension X-rays can't? What is flexion extension X-rays okay for? Yeah, so Cassian, as we talked about, there is a protocol I put together on YouTube that you can give an X-ray site that's doing a flexion extension X-ray that includes open mouth lateral bending views to try to replicate a DMX. As far as what a DMX shows versus an upright MRI versus a flexion extension X-ray, a DMX is going to be great to see type 2A, 2B, 3A, 3B, very similar to a flexion extension X-ray, but a flexion extension X-ray won't be able to see The type 2B, unless it's got that open mouth lateral bending view I just talked about, where there's a video on my channel that shows how to do that. And then for a flexion extension upright MRI, that's going to be really good at type 1A, type 1C. Not as good on 2A, can't show 2B, and not as good on 3A or 3B, but you may see it. Existential. Can airway myofunctional therapy help with CCI at all? I've been told a deviated septum and underdeveloped sinus can be problematic for CCI. We don't know that a deviated septum or problems in your sinuses have anything to do with CCI. So I don't think that's going to help. Now, it may help through other mechanisms, right? If you're overloading your whole TMJ complex to provide yourself with upper cervical stability, then you may get yourself in a situation where having someone work on the mouth through myofascial release and in the TMJ muscles, or even the muscles in the soft palate, may provide some relief because those muscles are chronically overloaded. Shane, do you ever see symptoms of neuropathic itch in an upper extremity rather than true pain in patients with mid-level 4-5 instability? Have an ADR at 3, 4, 4, 5, 6, 7. DMX shows a lot of excursion with extension. Is it possible? It is possible. The nervous system is involved in the immune response. But it's not the most common thing we would see. Now, since you have ADRs at 3, 4, 4, 5, and 6, 7, then I'd be really concerned about 5, 6, because ADRs are really the same as fusions. I know their build is better than fusions, but the research doesn't show that. But if there's an ADR at 4, 5, and you're getting 4, 5 type symptoms, then the easy way to do that is to treat the 4, 5 level. Let's say with an intra-articular facet injection at C4-5, it'll probably overfill around the nerve as well. And then you can see if that reduces these itching symptoms that you get. That would probably be the way to go there as far as trying to figure that out, yay or nay. Edgar, in 4 weeks, I am 4 weeks out from EPICL, starting to feel better, mostly functional with thoracic ligament laxity symptoms. How long would you recommend waiting after EPICL before targeting thoracic spine? You know, Edgar, I think you're going to be waiting at least another month or so. You know, as long as they can position you easily without having to mess up anything in your neck, you can do a thoracic spine injection. That's not the problem. Now, you wouldn't want to do a corticosteroid injection. You'd want to do a platelet-based injection, and realize that thoracic spine injections are high rarefied air injections. What I mean by that is you have to have imaging guidance. You have to have someone who's very experienced in injecting thoracic spine. But assuming you have a very experienced interventionalist who is using, let's say, fluoroscopy with contrast confirmation and using a platelet-based substance, and they're not going to mess up your neck and positioning you, then you can do that sooner rather than later. May I just, can someone have CCI without having a headache or much pain? I have mostly autonomic dysfunction symptoms and a very weak neck. Yeah, that is possible. We certainly do see that. It's not the most common presentation, so we would call that an atypical presentation. And, you know, we would use certain tiebreakers, right, to see if it is coming from your neck. So if you put a collar on, does that help some of the autonomic stuff? If we do an exam, does it localize to the upper cervical spine? All of those kind of things are going to be used to try to figure out if there's a connection between your autonomic symptoms and your neck issues. Amanda, would using Cipro eardrops carry the same risk as oral antibiotics in terms of possible tendon problems? Less so, because the systemic doses are going to be smaller. So you would think that there would be much less of a likelihood of getting any sort of tendon problems after a Cipro eye drop as compared to taking a Cipro pill orally or getting Cipro IV. Greg, should I get in touch with your office about upright MRI? You guys trust before meeting, coming from New Mexico, don't think they really know proper placements. Yeah, Greg, again, I think that having as much information is wonderful. So having as much information as we possibly can is always a net positive. Having said that, if what we're trying to get to is CCI and how to treat it, then oftentimes a DMX is enough. But I'll never turn away more rather than less information. So yes, our office can hook you up with the local upright imaging center that knows what we're looking for. Becky, Dr. Centeno, I've been your patient, but I do understand if not doing a PICL, we'll do one more round of posteriors. You won't see me again while I move to another doctor in the clinic. Is that correct? Yeah. So Becky, this is an important point. This year, I moved to 2 days a week clinical in the office. And to maximize my ability to see the patients most in need, I'm focused on PICL only starting in December of this year. So bottom line is that by December, I'll be PICL only, not able to see patients for posteriors, etc. Having said that, we have several doctors in the clinic, Dr. Pitts, Dr. Schultz, Dr. Merkel, who can do those upper cervical injections with you very easily. So by December, you'd want to be sighted with somebody else. And again, the reason for doing that for me was to try to make sure that I could see as many of the patients that were high need and more complex as possible. Andrea, I have CCI type 2. I received a TICL, maybe a PICL from your office, and I'm on week 2 post-procedure. What week do most clients get relief of neurologic symptoms? Yeah, so Andrea, usually it's 3 to 4 months before we even look at outcomes. So if you're younger, then I would say 2-month mark. If you're older, I would say 3 to 4 month mark. So realize that you've got a ways to go. Now, do people experience symptom relief before that? They do, but those are the numbers we generally hand out because that's when most of the people that will have responded will show some changes. Robert, what is the criteria for injection of the myodural bridge? Really, Robert, it could be one of 2 things. One would be on flexion extension upright MRI. We see bulging of the dura with extension, where the myodural bridge is supposed to control that dura right there between C0 and C1. Another could be that we see atrophy of the rectus capitis posterior minor on MRI, and they're tender over that rectus capitis posterior minor and myodural bridge area. So those are kind of some of the things we use to try to see if we need to inject that myodural bridge. Snowmass, can the CCI analysis app include reading MRI, DMX imaging in cases we don't have measurement numbers? Not at this point, although I don't think that's too far away, to be honest with you. I think we'll see that here out of ChatGPT, for example, by next year, probably. And I have heard some people just upload their images. I don't know how well that works at this point. I'd be a little bit scared unless it showed me exactly what it measured, and I, as an expert, could obviously look at it. But let me know in the comments if anyone's done that and how accurate it seemed to be. Thank you so much. I'll be meeting with Dr. Hepworth and MIPS in Denver, so I'll try to stop by the office when I'm there and schedule. Certainly, Ian, I don't know why I have CCI. It seems to fluctuate massively month to month. I've had some concussions, but these were many years before I developed symptoms. I don't think I have EDS, but it's a possibility. If, for example, the CCI is developed somehow due to some sort of unknown systemic issue that caused ligament laxity, I suspect it was COVID. It gets worse after each virus. Yeah, so I think, Ian, we don't have a non-trauma or non-EDS mechanism that can explain CCI right now. Now, it's possible that one develops here, but we don't have one right now that's convincing. So sometimes it's old trauma, and sometimes we don't know why. Ian, are you aware of any patients who have had jaw surgery who have had or have CCI? I'm due to have the double jaws advancement surgery, MMA, for sleep apnea due to recessed jaw. I'm wondering if this is going to impact CCI. Yeah, we have had CCI patients who have had jaw surgery, not a lot, but I want to say in my patient population, maybe 10 or so through the years. It certainly didn't help their CCI, and in a few, it may have made it worse or exacerbated it. Again, realize that many CCI patients are using the jaw muscles and other strap muscles in here to help stabilize the head on the neck. So if you lose that ability because we're changing this anatomy, that could not be a good thing. Greg, how important is proper CXA measurement for our first meeting, or would that be something to look at after? Meeting a person as getting a DMX day before, or should I do an upright MRI? Yeah, so bottom line here is, Greg, if you're getting a DMX the day before, then that should suffice. Now, if money's not an object, then I would say get an upright MRI as well. We'll look at that and we can measure a CXA pretty accurately. But if you're resource constrained, like a lot of patients are these days, then I'd probably just stick with the DMX for now. Essential. Can Botox for migraine be injected in forehead and temples only in a patient with CCI, avoiding the traps and occipital injections? Yeah, so facial cosmetic stuff would have the least impact. Then we would go on the list to forehead and temples are going to have some impact on CCI. And then Botox in the suboccipitals would have, and upper traps would have the biggest impact. So it's kind of in the mid-range impact area. Okay, guys, so we are just past an hour. So I'm going to start looking for some interesting questions I haven't yet fielded. Just looking through here. I think this is someone saying there's a DMX at Unruh Chiropractic in LA. Somebody had a question about DMX in California. Andrea is saying we have a place to get DMX here in Las Vegas. Thank you, Andrea, for reporting that. Maybe you can help somebody out who's looking for that. Jesse, I've been dealing with these symptoms for almost 12 years now. Went to doctors and specialists with no answers and just pushed through it all to about 3 months ago when everything went downhill fast. So the question is, could I have CCI for that long? And why did 3 months ago things spiral down so fast? Yeah, Jesse, as far as why, if you have CCI, why can it get better or worse all of a sudden? On the worst side, usually that means that structures that have been overloaded for a long time that were able to self-repair can no longer self-repair, and you push them into that danger zone. That's usually what happens when someone gets worse. So, these structures are no different than others in your body, right? You might be a runner, and as you get older, one day you find that you get knee pain and you can't run. Why did it happen that day? Well, you're getting older, and the cumulative wear and tear has started to create a problem. Casein is releasing a tongue tie, a scam. Well, if it's so much a scam as it is, I don't know that we really know it's going to do much for anyone's neck. So I've seen lots of patients do this through the years. I've kind of scratched my head on it, and wondered why, because I don't see pressing evidence or convincing evidence that there's a relationship between neck issues and a tongue tie. Are you seeing correlation with COVID, long COVID, and these issues? Certainly seeing patients who report that. We don't have much data that shows that COVID or long COVID causes CCI or is related to CCI. Certainly, I think those things can act as a catalyst to bring symptoms somebody has had that were minor and manageable to the forefront. And so I think that's generally what we see. Can CCI damage the kidneys? No, not something we've seen before. So I think that would be a big problem. Let's see. If cost is an issue and worst pain is facet joint C1, C2, I wanted to start with just posterior. What's the estimated cost for PRP posterior versus bone marrow? Just C1, C2 level. Thanks. It's definitely going to be cheaper, but again, and we always allow patients to do posteriors instead of a PICL, but you're going to need to get typed first because, for example, if it's a type 2B, then we're going to say, yeah, we can do posterior, and it may give you some temporary relief, but there's very little evidence that we have that it's going to help you long term. So are you just throwing away money? And that's something that we counsel patients with all the time. But in general, posterior injections for PRP in our clinic is going to be about a third of the cost of a PICL procedure. So definitely cheaper. Eric, if you're right about the muscle relaxer, I took 15 DMX in my skull. Yeah, so I think what Eric is bringing up here is that muscle relaxers or other medications can help patients get full range of motion for DMX. And again, full range of motion is associated with us being able to find instability if it's there. If you get less than full range of motion, then the instability may remain hidden. Robert, are you going to add both flexion extension BAI on the analysis tool and other measurements? Yeah, those are on there, Robert. There's a flexion and extension BAI on there. So the tool does lots of different measurements, BAI and translational BAI, BDI and translational BDI. C1, C2 rotation is on there, C0, C1 rotation, pretty much everything we use. Now, there's some things on there that we don't use. We don't generally use Chamberlain's line, nor do we think it's important in this patient population, for example, so that's not on there. Family member is basically looking into CCI and trying to see whether DMX or upright MRI would be the best. In general, if I had to place a bet without knowing the patient, a DMX is more likely to find craniocervical instability if it's present than an upright MRI with flexion extension. And then we have supplements that we designed for ligament and cartilage healing that you would get in our office if you came in for a treatment. Andrea, thank you for answering all these questions. I asked it twice because wasn't sure the answer. No problems there. Let's see. Dr. C, will treating rotator cuff tear with BMC affect the healing after PICL due to inflammation? Probably not, Julie. I don't think that one is really going to impact the other. Nathan, have you ever heard of vertebral motion analysis, similar to DMX? Yeah, so I have heard of VMA. The biggest problem with VMA is that they only do flexion extension. They don't do that upright lateral bending open mouth. And that's a key one for CCI because that's a very common type of CCI, type 2B. So on the VMA side, I would say you're probably not going to get what it is we're looking for out of a VMA. Stomass of spinal cord flattening is present with numbness on thumb, index, and middle fingers. Is too late to treat using regenerative medicine. I need to know more. I need to know the person's exam. I would need to know what instance or movement is causing the spinal cord flattening, for example. But in general, I would say that the likelihood of regenerative medicine goes down in those cases from maybe 80% to 60%. But we still see patients that have that respond. How much PRP is injected into the inner spinous ligaments? Not much, about a half cc per level. What am I drinking there? I think I showed this last time. This is this stuff, honey, wildflower, matcha tea from 7 Teas. So I don't get paid by those guys for a promotion at all, but I do drink a lot of their stuff. I've cleaned out most of the Whole Foods here because I like this one in particular. Greg, thank you for your info. Apologize on my tube. No worries there. Can suboccipital tendon damage cause dizziness? It's not suboccipital tendon damage. That's sort of something started by a chiropractor that does some tendon dry needling, and it's a little nutty. Dry needling is actually into the muscles, so suboccipital muscles. So suboccipital muscles can develop trigger points, which can cause dizziness. And you can treat that with trigger point dry needling. Now, I suspect this chiropractor has decided to call it tendon dry needling, probably because some sort of issues with licensing in his state allows him to dry needle a tendon, but not a muscle. But yeah, you can dry needle the suboccipitals here. And if someone just has craniocervical syndrome, you might be able to help them more longer term. If someone has craniocervical instability, you're probably not going to help them long term that way. Kian, I'm post-spinal surgery patient, had your injection in my spine by Dr. Schultz last February at your clinic. Things done improved in addition to extreme weakness in my dorsal flexors, and then it stops. I have severe cramp in right foot muscles. What can be the reason for it? Kian, I don't know your history at all. I don't know what's going on with you, so I really can't answer anything about that. Obviously, Dr. Schultz may be able to, but I don't know what your condition is. I don't know what injection was done. I don't know whether the injection was likely to help, unlikely to help, etc. Have you seen EDS patients with CCS and not CCI? Absolutely. Okay, guys, we are at 1 hour and 12 here, so I'm going to start wrapping this up. I will try to do a Facebook Live this coming Wednesday, to do this one more time before I go on sabbatical. And I'll be gone for about 5 weeks. Now there'll be YouTube shorts coming out every day, and I will be answering questions on the Reddit sub during the time that I'm away. But I won't be doing Facebook Lives while I'm away. So I'll try to get one more out probably this coming Wednesday, and then we'll go from there. I want to thank you so much for all your great questions today, because this whole thing works through patient questions, and there is no such thing as a bad question. We all learn something from our own questions. We learn something from other people's questions. And at the end of the day, as I always say, an educated patient just does so much better than a patient that isn't really sure which end is up. So that's my goal here. Even if we never see you at Centeno Schultz, the goal is to try to educate as many patients as possible about this stuff so they can get the best care possible. So I'll try to be here this coming Wednesday, and I will see you then. And in the meantime, have a great rest of your weekend and great Labor Day, not Memorial Day. Labor Day coming up here on Monday. Thank you.